Hi everybody, my name is Emil Zenov and I'm the manager of the European HCM Patient Foundation, which organizes the HCM Pills webcast series. Today, I'm standing in for Niccolo Maurizi, who is the main anchor of the webcast but will take a temporary break because of family obligations. We would like to welcome you to the 9th episode of HCM Pills, a series of webcasts on diverse topics concerning hypertrophic cardiomyopathy. We will bring you the best HCM experts to answer the most needed and useful questions directly from patients all over Europe. Remember to comment on the video and ask questions that interest you to help us decide on the topics of future webcasts. The HCM Pills webcast is organized by the European HCM Patient Foundation, a non-profit patient organization aiming to provide help and reliable information for patients diagnosed with HCM all over Europe. I'm here today with Dr. Ahmad Masri, who is the Cardiomyopathy Section Head at the Oregon Health and Science University. He is a recognized authority on HCM and amyloidosis, shaping the future of patients with these diseases by acting as a principal investigator for almost all recent important trials of new drugs in the field. So, Ahmad, let's go to the heart of the problem. It's an exciting time for patients with genetic heart disease and thicker hearts like us. Can you briefly explain for our audience why is it important to understand the cause of the hypertrophy and how can we differentiate HCM with respect to amyloidosis?
That's a great question. First of all, thank you for having me here today. It's really a pleasure. In terms of the hypertrophy, which means thickening of the heart muscle, there are many causes. It's the same as saying, I'm short of breath. Well, we can't really treat you just for being short of breath. We have to figure out why you are short of breath. Same thing applies to hypertrophy. When someone gets an echocardiogram or an EKG or whatever they get, and they get told that you have thickened heart muscle, what is the underlying cause? Is it just high blood pressure, uncontrolled? Is it kidney disease? Is it related to hypertrophic cardiomyopathy, which is in general, we term it as an unexplained hypertrophy that cannot be accounted for by other diseases or findings? Or is it, as you alluded to, for example, something like amyloidosis, where we consider it a copy almost of hypertrophic cardiomyopathy, not in the advanced stages, but in the early stages, because it could look like it. And what happens with amyloidosis is that you have a parent protein, and that parent protein goes rogue. So it starts falling apart, depositing in the heart muscle, making the wall thicker, but it's actually not making the muscle stronger. That's the difference from hypertrophic cardiomyopathy, which is a true increase in the muscle thickness related to the increase in the size of the cells of the heart. In amyloidosis, that's not what happens. What happens is that the heart is there, the muscle is there, and you have protein sitting between the cells that make the heart thick. The reason why it's important to differentiate, the treatment is absolutely distinct, different, and what you can use for one, you can't use for the other. And so that's why it's really vital to do that.
Thank you very much. This is very clear explanation. Just for us to better understand, you are involved with many drug trials. How do you arrive from an idea of a drug to the point of giving it to the patient? What happens in between?
Excellent question. So there are many steps between the two. And so first, you have a drug and you have a mechanism of action that you believe it's going to be beneficial based on the science that we already know about the disease. Then you have to go through a series of what we call preclinical testing. So that involves understanding more the drug, the mechanism of action, how does it distribute in different tissues and organs and whatnot. And then you have to make sure that it's not toxic. Mm-hmm. So the drug can work, but if it's toxic and it's not usable, then there's no reason for it. And so after you finish the preclinical testing series of things, then you will have to go to the clinical stage. The clinical stage starts with a phase 1 evaluation, which is, in a way, sometimes can be even healthy people. I'm going to just see what happens with this drug when I give it to healthy people. And then you progress from these phases, what we call phase 1, phase 2, phase 3. The trials that our patients are more familiar with are the phase 2 and 3 investigation. Phase 2 tend to be on the smaller scale. You're just trying to see the practicality of using the drug, the safety of the drug, and do you have any markers that it's actually working or not. And then you move to the main one. The main one is the phase 3 trial, which we power it, meaning we include enough patients to show that the drug is effective. And we usually do it against something. That something can be placebo, which is a matched inert substance that doesn't do anything, or sometimes it's an open label, meaning that there is no control for that arm of the treatment, or sometimes, like the most recent trial in HCM, it's against an established therapy. So that's what we call a head-to-head trial. So once you finish all of that and you show that the drug is safe and effective, then you have to go ahead and submit an application to the regulatory authority in whichever country you live in, so that you can get the drug approved there.
Mm-hmm. So you're alluding to the comparison between myosin binding inhibitor and beta blockers?
For example, yeah, the MAPLE HCM trial, which was just reported three weeks ago at the European Society of Cardiology meeting, aficamten as a program really took a very bold move, which is not common in cardiology, at least at this stage, in the early stage of these drugs, where you take a drug and you compare it head-to-head against another drug, which is in this fashion metoprolol. Metoprolol is a reflection of a bigger class that many of our patients are used to, something called beta blockers. They are widely used in many different indications. One of them is HCM. And the idea was, what we observe in clinical practice is that metoprolol or beta blockers can sometimes slow patients down. So is that just means because it slows the heart rate down so you feel a bit tired and fatigued, or does it actually do more than that? And what the trial showed is that metoprolol decreases patients' ability to exercise. So while it might give you a slight benefit in symptoms, maybe, it makes you essentially less able to exercise. And so that is moving us forward in this field, where in hypertrophic cardiomyopathy, we're getting to a point where we want to use medications that are specifically designed to address the underlying problem in hypertrophic cardiomyopathy, not essentially target other mechanisms that could help or might harm sometimes.
And this mechanism, this indication of physical ability is measured by the VO2, the peak oxygen intake?
Correct. And so what we do essentially is that we exercise patients, and one good metric in terms of exercise is to do this cardiopulmonary exercise test, which is a measure of how much, in a way, oxygen the body is able to consume, and how much carbon dioxide the body is exhaling, and then through a complicated approach you can calculate the efficiency of the heart muscle. And that's what peak VO2 is. And what you want to see with interventions, you want to see peak VO2 go up with interventions. You don't want to be seeing it going down. And so we've run trials on placebo where the peak VO2 on average stays the same. But metoprolol in this trial, MAPLE HCM, reduced peak VO2. So it makes you actually do less in real life.
Clear. And just one final clarification on this question. Who determines the markers of how a drug is doing? So who is actually determining and placing the values of the markers?
Yeah, that's a very good question. It depends if you want the drug to end up coming on the market specifically for that indication, or if you already have a drug and you want to just see if it works in this disease. If you want that specific indications, you have to discuss this with the healthcare authorities. Usually they want two things. They want to improve patients' feel and function. So one is symptoms, either patient-reported symptoms or physician understanding of the patient-reported symptoms. So that's the feel. And then the function is usually either using an exercise test, using peak VO2, or using something along these lines. You have usually to improve these two things to get to a drug to the market.
Clear. Thank you very much. So now that we have understood the mechanisms of HCM, could you please tell us about some of the new drugs that are being currently developed and their targeting disease mechanisms?
Definitely. So I'll be brief. The big group of medications that has been lately, highly investigated in hypertrophic cardiomyopathy is cardiac myosin inhibitors or modulators as well. There's a new drug that is there, and so which is addressing part of the muscle where you have too much activity happening between the fibers of the heart muscle. And so you use these drugs to reduce that. That includes mavacamten, aficamten, and then a new medication called EDG 7500. And so these medications are meant to reduce the excessive force and the excessive amount of interactions that are happening in the heart muscle. So that's one big family there. The second group is the group of medications that are focused on more on the metabolic side of things and the energy side of things. So niraparib is a drug that is focusing on shifting the energy use in the heart to glucose use, which is considered a more favorable energy source under stress. And so that's another drug that is being in development. Another drug also is called sotagliflozin, which is a combined SGLT1 and 2 inhibitor. It's already available on the market for other indications, but here we're specifically studying it for hypertrophic cardiomyopathy to improve myocardial metabolic health and to improve the myocardium so that in turn patients actually improve in their feel and function. And then finally, there are a few programs focusing on gene therapies. And so what these programs are trying to address is if you have a single mutation in your genes that is causing hypertrophic cardiomyopathy, can you supply a normal protein in that copy, in that gene? Can you give normalize the gene to normalize the protein and actually try to either arrest the disease from progressing or reverse the disease? It's still early, but that's the promise there.
All these are very, very exciting. Coming back to amyloidosis, which, as you mentioned, is a very different disease and with different treatments. One thing that was common with HCM was that until recently, both diseases were more or less treated for their symptoms, not for the underlying cause of the disease. How do we target the disease now, amyloidosis?
Yeah, great question. So with amyloid, we've done a lot of things in the last 10 years. And lots of progress have happened. The two most common types of amyloid are called light chain amyloidosis and transthyretin amyloidosis. The one that is really common nowadays is transthyretin amyloidosis. And it's typically both of them, but mainly the transthyretin type is an age-related disease, where as we get older, we have tendency to have these proteins start to sit in more places in the body, including the heart. And so the treatments now are very effective in addressing the underlying protein problem. We don't have treatments to improve patients, meaning that's why diagnosis is so important, so that you can intervene early to prevent the progression of the disease. In HCM, we can improve the patient's feel and function. In amyloid, our goal is to prevent progression of heart failure and death and progression of worsening of symptoms by controlling the underlying source of the disease. But we don't yet do or have medications available on the market that allows us to improve the patient's feel and function from baseline. However, we have few clinical trials focusing on this group of medications called depleters, which are hopefully in the future going to be able to allow us to not just only control the source of the problem, but also improve how the patients feel over time.
Great, that's a very clear overview. Do you think that any of these drugs that you just mentioned might really be able to cure the disease or maybe even achieve a regression of the disease? For example, I have cardiomyopathy and I get these new treatments and the disease disappears. Or for example, with a child which is diagnosed with a gene, can we do something to stop this gene from actually developing?
So there are a few things to unpack there. First of all, the future is bright. I can promise everybody that, because what has happened in the last 5 years was unexpected, unprecedented, and the next 5 and the following 5 are going to continue to be, really as good as we've observed the ones before. Now, in terms of regression, in HCM specifically, it depends on the situation. Every patient is different. In some patients, you actually do see improvement and regression of the amount of thickness, on the amount of remodeling that already have happened, and patients improve from baseline a lot. And so that already is happening. The question is, should we intervene on the disease much earlier than we intervene right now. Exactly. And we probably should conduct a clinical trial to get at that. So hopefully, I think in the next few years, we're going to have a trial at an early intervention even before symptoms become a significant issue. Because we know everybody starts before they have symptoms, and once they have symptoms, maybe you're actually waiting too long for that. So we'll have to conduct a trial to show this. The second point about genetics is that we still don't know who's going to express the disease and who's not going to express the disease. So to go and treat people with the idea that they might in the future develop the disease or not, I think it's still pretty early there. But for patients who have early disease, if some of these genetic-directed therapies are safe and effective, then the natural progression is to start and thinking then after that is how can I deliver them earlier so that I stop the disease from ever progressing. But I think we're early.
Mm-hmm. About the trial that you mentioned, it looks like a very longitudinal trial. How many years should we actually wait for this to be determined?
Yeah, if we're using, for example, a myosin inhibitor to address disease early, I think we can design the trial to not be very long, because then you can sub-select for certain patients and you can see how their response is. So the inclusion-exclusion criteria in this trial allow you to run a reasonably sized trial with a reasonable duration of follow-up. In terms of the genetic component of these trials, if you run a gene therapy directed trial, these trials tend to be on the longer side.
Clear. And how important is it to understand the quality of a patient's life? How do we measure it now in daily practice and in these trials that you are doing, the quality of life?
Well, it's very important. Ultimately, what we do here, everything we want to do is influence the structure of the heart muscle, but ultimately the goal is to make the patients feel better. And if the patients can articulate to us that my quality of life is better, that's really an important goal. And so clinically, you assess symptoms, you assess the patient story, the transitions over the years, how things are going for them. You can use questionnaires as well to reflect on how they're feeling, and you combine that with the objective evaluations that you do. In clinical trials, it's a lot more standardized and rigorous. So lots of questionnaires, lots of assessments. I don't necessarily think that you need that in real life, but in real life, what you need to do is to make sure that the patient is responding with symptom response, with quality of life response, with objective response, so that you actually can say that the patient is responding to the therapy at that point in time. But without the patients feeling well right now in HCM, we don't say that we actually met the criteria for response. The criteria right now for response in HCM is quality of life. We don't do now interventions to increase the duration of life, even though we say most likely these drugs will actually help you live longer. It's not proven. Even for surgery, when we used to do a lot of these myectomies, the goal is to improve the quality of life. So that's important in hypertrophic cardiomyopathy.
And the final question, how can patients and their organizations, like our organization, help medical progress in this very fast developing field?
So I think you're already doing a lot of great work by improving things, by increasing awareness, by educating other patients, other physicians, other communities about this. So that's part of it. The other part of it is being proactive. You have to remember that we can't actually get a drug to progress or to anybody without the patients. So it's really mutually beneficial, but at the same time, the patients are the drivers of this. And without the patients, we can't get anywhere. And ultimately, the treatment also is for the patients. And so being proactive, trying to learn more about what's going on. When you go see somebody, even if it's in a small practice, ask, is there a clinical trial for hypertrophic cardiomyopathy that I can be part of or participate in? And if that individual physician or practice is not helping you, they can reach out to you, to your organization, or they can reach out online and find resources for this.
Thank you very much for your valuable time and very clear responses, Ahmad. Thanks also to our sponsors for making the webcast possible. We hope that this brief discussion with Dr. Masri was useful to better understand your disease and yourself. Remember to like, subscribe, share, and comment to help us get the word around and decide the next important topics of next webcasts. See you soon.